All right, for the sake of time, I think we can go ahead and kick off our presentation here. Thank you for joining us. I am Carrington Lott. I'm the Deputy Director at Systems for Action, which is the National Research Program Office of the Robert Wood Johnson Foundation. We're located in Denver, Colorado at the Colorado School of Public Health in the Health Systems Management and Policy Department. And we have been funded for the past 7 years from Robert Wood Johnson Foundation to fund studies across the United States that are aimed at identifying strategies for alignment across systems, and those systems are the public health, medical, and social service systems. And today you are going to be hearing from our team at SIREN, the social, I want to make sure I get the name right, Social Interventions Research and Evaluation Network, and their partners 211 San Diego and Health Leads. And they're going to be talking about their project that is in the first of 3 years that we're going to have them in our Systems for Action family, that is looking at evaluating the effectiveness of California's CalAIM Medicaid waiver program and identifying key facilitators of cross-sectoral care coordination. Next slide, Caroline. Thank you so much. So this is our agenda or snapshot of what you can expect to hear about today during the presentation. We are in our welcome section right now. And as soon as I go over a couple of housekeeping items, I'll hand it over to the team so that they can tell you about their really exciting research. And then they will have commentary from Glenn Hilton from People Assisting the Homeless. And he will be talking about the impact of their research. And then we will save the last 10 to 15 minutes for some questions and answers. So with that, some housekeeping things. This is a session that is being recorded, and we will email out the recording as well as a PDF of the slides after today's session. And if there are any questions that come up at any point during today's presentation, please locate the box at the bottom of your Zoom screen, the Q&A box, and enter it in at any point, and we will make sure to address that at the end of today's session. Next slide, Caroline. I think it's time to hand it over to you, what the people came to hear about. So I will hand it off.
Great. Thank you so much, Carrington. It's really a pleasure being with all of you today. Thanks for joining us. I'm Caroline Fichtenberg. I'm a co-director of the Social Interventions Research and Evaluation Network at the University of California, San Francisco. I'm really excited to be talking to you about our project. I want to introduce first our research team, our project team. So we are at the University of California, San Francisco. We have myself, along with Abigail Ahrens, who you'll hear from later in the presentation, as well as Danielle Hessler-Jones and Laura Gottlieb, who are the other two co-directors of SIREN, and Priscilla Alban Acuna is also part of the team. This project is a partnership with 211 San Diego, which is the 211 system for San Diego, and also the organization that has created the Community Information Exchange in San Diego, a system to facilitate cross-sector collaboration and coordination. And today we'll be hearing from Karis from that team. And then we also have a partnership with Health Leads, and Sheena's on the call today from Health Leads. And then I also want to recognize the California Healthcare Foundation and Goodwin Simon Strategic Research, who we have we're partnering with on part of our project as well. Great. So what is our project about? We are funded to look at the implementation of something called CalAIM. CalAIM stands for California Advancing and Innovating Medi-Cal. Medi-Cal is California's Medicaid program. So CalAIM is a Medicaid reform effort that began in January of 2022, and it really seeks to do three things: to implement a whole person care approach that addresses social drivers of health, to improve quality outcomes, reduce health disparities, and drive delivery system transformation, and to create a consistent, efficient, and seamless Medi-Cal system in California. As our governor has said, this is a once-in-a-generation opportunity to completely transform the Medicaid system in California. And so this is really a big, it's a set of really big changes for Medicaid that have been happening in California. There are two key features of CalAIM that are particularly innovative and that are the focus of our project. The first is something called enhanced care management. And this is intensive care management for medical and social services for the highest need, highest cost members. And there are a number of populations of focus that I will show you on a subsequent slide. And this is a managed care benefit. So it's only for managed care beneficiaries, which are the vast majority of California beneficiaries. And it's something that plans have to cover. And I mentioned this because this is in contrast to the second very exciting feature as part of CalAIM, which is called community supports. And this is where Medicaid dollars can go to pay for 14 non-medical services for Medicaid beneficiaries. And it's through the in lieu of services feature of Medicaid, which means that it's strongly encouraged, but not required. And the plans choose which ones of these non-medical services to cover. This is a particularly new and exciting part of Medicaid, and that only a few other states so far have gotten the permission to do. And so when I mean new and exciting is, again, this piece of actually paying for non-medical services to address social drivers of health. These two features are building on previous pilots that happened in California, the whole person care and the health homes pilots that combined elements similar to enhanced care management and community supports, and that had led to improvements in health and also reductions in healthcare costs. A key feature of both of these is that plans contract with community-based providers to provide both enhanced care management and community supports, ideally right in the community. And so the idea and the other big thing about CalAIM is that it's bringing into the Medicaid ecosystem a whole set of new health providers of non-medical services. Other thing I want to mention is that CalAIM does include a fair amount of dollars for building up the data sharing and cross-sector coordination capacity among ECM and community supports providers. And so it's not only providing opportunities for new organizations to provide services to Medicaid beneficiaries and get reimbursed for that, but also providing dollars, one-time dollars to build up capacity. Just a little bit more about these different services. So the enhanced care management is really meant to be the top of the pyramid for the highest needs members, and is meant to be coordination for health and health-related services, i.e. social drivers of health services. Just to give you an overview of the populations of focus that are eligible for the ECM, the enhanced care management benefit. They are individuals experiencing homelessness, individuals at risk of avoidable hospitalization or ED utilization, individuals with serious mental health and or substance use disorder needs, individuals transitioning from incarceration. And just so you know, that population actually is not yet, we haven't yet moved to ECM for that population. That's going to be happening later this year. Adults living in the community and at risk for long-term care institutionalizations, adult nursing facility residents that are transitioning to the community, children and youth enrolled in special services and also involved in the child welfare system, individuals with intellectual or developmental disabilities. And then there's also a strong focus on pregnant and postpartum individuals, and particularly with the focus on populations that experience inequities in birth outcomes. And it includes both adults and children. And then here are the 14 non-medical services that are can be paid for can be provided to beneficiaries through the community supports. As you'll see here, it's a lot of housing supports, a lot of things that are helping people transition from institutionalized settings to be able to live in the community. And then also number 12, medically tailored meals. And then sobering centers, asthma remediation, and going back to number 11, environmental accessibility adaptations. So that's the universe of things that can be paid for with Medicaid dollars. And for each of these, there's a specific population that's eligible for these. And again, these are not, these are provided as in lieu of services. So plans get to decide which ones they want to provide. But for the most part, plans have been picking a lot of these, and particularly the housing. I will show you that in a minute. Just to emphasize this again, one of the key things about ECM and CS is that it's bringing new kinds of providers into the Medicaid fold in California. On the ECM side, in addition to FQHCs and behavioral health organizations that were providing Medicaid services for a long time, we also have organizations like homeless service providers, justice-involved service providers that are likely to be interested in providing and able to provide ECM services. And then on the community support side, the organizations that are likely to provide these kind of services are a whole range of social service organizations providing these kind of services. And so one of the key questions about CalAIM and one of the keys to CalAIM success is going to be coordination between health and social service organizations, including cross-sector contracting, data exchange, and coordination to avoid duplication of services. And so one of the big questions is, is this happening effectively? And what are the factors associated with enabling this to happen in this context? I want to give you just a little bit of data before turning it over to Abby about how things are going so far. So far, as of the most recent data available, which goes back to September 2022, there were nearly 1,000 organizations contracted to be ECM providers statewide, and nearly 90,000 members who had received ECM services statewide. And this chart shows you the most common services that are being, or populations that are receiving the ECM services statewide. So nearly 50,000 who are adults at risk for avoidable hospital emergency department use, 35,000 adults with serious mental illness or substance use disorders, 25,000 adults experiencing homelessness, and a few thousand adults transitioning from incarceration. Going to the community supports implementation, we have about 12, as of last September, about 1,200 organizations contracted to provide community supports, and about 27,000 members who had received services. And as you can see here, the most common service that is being provided are housing tenancy and sustaining services, followed by housing transition navigation services. And then medically supportive meals coming in as third, but with a lot less volume. Want to show here that across California, this shows all the counties in California, and in different shades of blue, how many community supports are offered by the plans there. And as you can see, there, as of last September, there were 3 counties that were providing where plans, at least one plan was providing all 14 community supports. The vast majority of counties, nearly all of them, were providing between 6 and 13 community supports. And then 2 counties where plans were offering fewer than 6. And then in terms of which community supports are most likely to be provided, this shows as a percentage of all of what the plans are offering across all the counties. So nearly all of the plans in all the counties are offering the housing tenancy and sustaining supports, the housing transition navigation, and the housing deposits, as well as the medically tailored nutrition. So those 4 benefits are basically being offered nearly in every single county by every single plan. And then it kind of goes down from there in terms of the other benefits that are available. So even though these are optional, we are seeing that there is high uptake on the plan side for at least the first 4 of these on this chart, and relatively high for a lot of the others as well. And this is data as of February, so it's slightly updated from the map that I showed you. Great, I'm going to turn it over now to Abby to tell you what then we are trying to learn about this program.
Thanks, Caroline. So as Caroline mentioned, I'm Abby Ahrens. I'm a fellow with Siren at UCSF. And I'm going to talk about this research study that we're doing as part of our Systems for Action project today. So clearly there's so much that can be learned about CalAIM. And so we're honing our focus for this study on 2 key research questions. So the first is CalAIM improving coordination across the health and social service sectors, especially with a focus on beneficiaries from historically marginalized communities? And then second, what factors or at the organizational and environmental level can make that coordination more or less successful? Next slide. So our project comprises 3 main activities, each of which we're going to talk about in more detail. So the first is a survey of social service organizations that we're fielding this summer. The second is a series of local case studies for a deeper dive that we'll do next winter. And then already ongoing is the community of practice that really is an opportunity for us to learn more about the experiences of some of the backbone organizations involved in implementing CalAIM. So a bit more about our survey, which is set to be fielded next month. This is the first statewide survey on this scale about CalAIM implementation. And as we mentioned at the beginning, we're partnering with California Healthcare Foundation and Goodwin-Simons to field this as part of a larger survey effort. And that survey includes healthcare payers, public health, other entities, and we're really focused for our piece of it on the community-based organizations side of things. And our current plan is we'll field it this summer, and we're hopefully planning a follow-up survey and 1 year later next summer. Next slide. So we have 2 main goals with the survey. The first is to understand the organizational and environmental factors associated both with whether community-based organizations are even participating in ECM and CS at all. And then the second is we're going to look at those same factors and their association with a number of measures of effective coordination between social service and other sectors. For example, measures of data sharing and referral processes and contracting. And our second goal is really the specific focus that we're elevating on organizations that serve historically marginalized communities. First, whether these organizations are effectively able to participate. And I should mention that our survey covers both organizations that are participating as well as organizations that are not participating or are not yet participating in CalAIM. And then second, we're going to solicit recommendations of changes that can help these organizations participate in ECM and CS more effectively. Next slide. So for the second piece of our project, while we hope that the survey captures the breadth of CalAIM activities, we plan to supplement those findings with a deeper dive in 5 counties to have a better understanding of a more nuanced, comprehensive perspective of what's going on at the ground level with CalAIM implementation. So we're going to use this as an opportunity in 5 counties that we'll select to be representative of different types of counties in California. And we're going to interview social service organizations, as well as our hope also to include interviews with actual Medi-Cal members in those counties to better understand their experiences. And this survey, the case study effort will be next winter. So now at this point, I will turn it over to our partner organizations to tell you a little bit more about our community of practice. So I think that's you, Karis.
Hello, everyone. So my name is Karis Grounds. I'm the Vice President of Health and Community Impact at 211 San Diego. Just to begin a little bit about who we are, many of you might know about 211 since they're a national 3-digit dialing code across our country and Canada too. But we are a free 24/7 dialing code that people can call in and help people navigate to health, social, and community resources. We are in a local nonprofit in San Diego providing these services. But we steward something called a community information exchange, which is essentially really trying to provide how do we support person-centered care from a community lens through community care coordination? So what infrastructure is needed to support data sharing, cross-sector collaboration, kind of unique, innovative ways to think about innovation to really improve health and wellness for individuals and populations. So that's really what CIE is intended to do. And if you go to the next slide, we are leveraging kind of our best practices and opportunities to be able to kind of support that work. And I'll kick it over to Sheena from Health Leads, who's one of the other partners that are supporting this work as well.
Thank you, Karis. My name is Sheena McKinley. I'm the Vice President of Research and Development here at Health Leads. And Health Leads is a national nonprofit focused on advancing racial health equity. And then within that, our R&D team is really focused on community-driven innovation. So part of this includes partnerships like the ones for this project. And we've been working together with 2-in-1 San Diego for several years now and have had the chance to run a national community of practice amongst backbone organizations in early stages of operations and implementation, really drawing lessons from the components of the CIE. And so we're so excited for this project where we can learn about the early stages of implementation within the context of CalAIM and looking at a statewide community of practice. So this is such an exciting time to kind of learn in an organic peer learning environment about what's coming up for organizations in the context of CalAIM. And with that, I think we're going to move to the next slide.
So by leveraging our local kind of best practices, lessons learned from how we built CIEs, as Sheena mentioned, we've been supporting other communities across the nation and specifically in California, as Carolyn kind of outlined, the changes that are happening in California create a lot of really amazing opportunities to leverage CIE-like models to support innovation and identify challenges and really elevate what solutions could be done around data sharing initiatives, around community infrastructure to really, since we're looking at changing the systems, what does that mean from a technical side and a collaborative side to be able to do that? And so this community of practice is really looking at convening different organizations across the state of California and looking at what are those common challenges, what kind of approaches or strategies could we be thinking about, who are the community stakeholders at the table really informing the way that we're doing the work. So a big goal of CIE is really centering community voice and really bringing in all the organizations that are doing the work. And so how do we really look at how is that informing the CalAIM work that's being done within communities? Could we look at recommendations and lessons learned from one another? And again, it's the opportunity to kind of, with UCSF, look at that real-time kind of evolution, since it is over the next 3 years as new legislative changes are happening. We have a pulse on real-time changes that are happening within community. So we've already launched those community practice meetings, but we're going to continue to regularly meet to really dive deeper into a lot of these concepts. So if you go to the next slide. These are some of the communities that we have initially engaged with, but we're reaching out to other communities. So everywhere from Northern California down to Southern California, we tried to get some array. We are looking at engaging some additional Imperial County as a rural county out in San Diego. There's elements of most all counties that have rural aspects of these bigger cities too, but we're also intending to reach out to some of those smaller communities as well. But this is kind of the start of our community of practice and trying to engage those that are already in the work now. And if you go to the next slide, this is a little overview of what type of concepts we're specifically thinking about. So a lot of the work as Carolyn again outlined, what does CalAIM mean? It means it's a lot of things are changing and shifting. And so in that, there's a lot of regulatory compliance and quality measures. And like for us to actually do the policy, as many of you know, the local implementation is the hardest part of that. And so interpreting a lot of that information and like then what needs to happen in as different organizations are working with maybe the same people, different community supports, like the housing, and maybe food and, you know, home modifications, whatever that might look like. There are different organizations providing those services. And then you have health plans interacting in that as well and other healthcare systems. So it does require a lot of community care coordination for us to be able to support those individuals. And so some examples, we're looking at closed loop referral, really streamlining the referral and intake processes across different systems. How do we ensure continuity of care as people are hopping across these different systems? Are people able to engage and see where people are enrolled or being supported elsewhere? Provider capacity, being able to kind of expand that, data sharing that could really support care coordination. So these are some of the topics we are going to be talking about in this community practice that will hopefully elevate best practices, lessons learned, collaborative efforts across the state to kind of move towards that successful implementation of CalAIM. And lastly, this is just, maybe this is last, I think so, right? And then I kick it back to you. But they're just really thinking about it from micro, meso, macro. This is one thing that we always have had a slide on forever, and just really community stewardship is a huge piece, person-centered care. And then the third thing is the multi-level impact. And I think where this becomes unique and really needed in these type of projects is thinking about things from an individual lens, thinking about things across systems. So like different agencies or healthcare, social services, government collaborating together. That's really how do you make that more efficient and effective to support people? And then from a macro lens, what's the impact from a community population health wide lens? And so that's really the goal of CA-like models is evaluating and looking at all those three of those things. And so that's really what we wanted to just close with from a opportunity standpoint of the community practice. And then Carolyn, I'll kick it back to you, some of the outcomes.
Yeah, thank you so much, Karis. And so the community of practice, as Abby mentioned, gives us an opportunity to be observing real time what the challenges are in organizations that are helping to provide that connective tissue to connect all these different sectors. Just to end, before turning it over to Glenn, want to highlight what we expect some of our project impacts to be. So one of the first ones is we hope to identify some recommendations for the state Medicaid agency for them to be thinking about in terms of improving the effectiveness of the implementation of CalAIM. We also hope to provide some guidance to other organizations seeking to support CalAIM implementation. As we see in the Q&A questions, you know, there are a lot of other players in this space that are helping to support CalAIM implementation. And we are trying to work alongside them, learn from them, as well as help to inform their efforts. A third thing is that we know there's a lot of other states that are looking at California and interested in potentially following somewhat in the same path as what California is doing. And so we hope to provide some guidance to other states about what are some of the things that are really important when trying to bring community-based social service providers into the Medicaid ecosystem. And then we also hope to help lay the foundation for an effectiveness evaluation. Our research project is really looking at the implementation of the project, but then the next step will obviously be to look at the impacts on beneficiaries. And we plan to produce policy briefs, academic publications, as well as do a lot of dissemination through presentations. Great. Now I am going to turn it back to Karis to introduce our commenter, who's going to give us kind of some real on-the-ground experience of implementing CalAIM as a community-based organization providing social services. Karis, over to you.
So, well, I'm just going to basically repeat what Caroline said. Glenn has been a great supporter of our local infrastructure and is a great example of an organization that is doing the work on the ground and really trying to think about systems change and like how do we become more innovative and supportive of this work. So Glenn from PATH joined in May 2019 and served as supporting different clinicians and really for the whole person wellness. So if people have heard about this, we've had a lot of different iterations of this work in California that has kind of stemmed into what we now call CalAIM. And so his historical knowledge and his day-to-day work is just amazing. And he's not only a colleague, but a friend. So Glenn, kicking it to you to give an overview of the impacts of this on your organization and the work you're doing now.
Great. Thank you, Karis. I really appreciate the lovely, warm introduction. I'll speak a little bit more about the fun that we've had together in our collaborative meetings within San Diego. Welcome, everybody. I appreciate being invited to talk a little bit about this experience of CalAIM. It has definitely been a learning experience for our locality and for individual providers in this space. So if we can go ahead and go to the next slide, I thought it would help just to give a little bit of background around PATH and who we are. PATH is one of the largest homeless service providers in the state of California. And across the state, we help people find permanent housing and we provide case management. We connect people to medical and mental health care, benefits advocacy, employment training, and other services to help them maintain their homes stably. So our mission is to end homelessness for individuals, for families, and for communities. And we do envision a world where every person has a home, which is a really daunting thing right now because of the number of people that are losing their homes on a daily basis. So we recognize it's an uphill climb and we're really committed to it. So the things that really drive us, our values, include creative collaboration, such as the ones that we have around our CalAIM projects, strategic leadership, empowerment for all, and a passionate commitment to end homelessness and to support our clients. So that is the big picture of who PATH is. Most of our work as a community based organization is not medical in nature. We do connect with the medical world a lot. And so stepping into the CalAIM Medi-Cal arena has been a real new first step for us. If we can go to the next slide, I'll share just a little bit about San Diego in particular. I am from the San Diego region. I'll share a little more about the other PATH counties that we're also doing CalAIM services in, but just a little bit of a profile of San Diego. We have 33 providers in this county of San Diego providing some form of CalAIM services. Some are providing more than one. So we have 12 providing enhanced care management, 17 that are providing housing related community supports. Those are the three that were the highest utilized on the chart that you saw a little bit earlier. So that's housing navigation, housing tenancy and supportive services, which is providing ongoing supports once someone is housed, and housing deposits, which are funds that are pass-through funds that help individuals move into housing with those initial upfront costs. So we have 17 organizations providing those. We have 5 organizations providing recuperative care and short-term post-hospitalization housing in San Diego, and 21 organizations that are providing one or more other community supports. So within PATH, I've actually got updated information since this slide went out. So we have 3 counties that we're providing CalAIM services in right now. San Diego, we have 6 health plans that we started working with on day 1 of CalAIM. In Los Angeles, we had 2 health plans, and in Orange County, there is only 1 health plan. And so we're operating with that health plan. We are only working with 3 health plans today. The reason for that is 2 of those were continuity of care only contracts. So we just continued serving people that we were already serving until they graduated from the program. And 1 health plan has actually ceased coverage within the county since CalAIM began. So we're down now to 3 of the health plans that we originally started with. Orange County is our newest county. They just started providing services there on October 1st. And the services being provided in each of those counties is listed below. I will provide some clarification though. All 3 counties were providing the housing suite, the housing transition, housing tenancy, and housing deposit services, not just in San Diego and LA. And then recuperative care, which is care to either avoid hospitalization or care upon discharge from a hospital, and short-term post-hospitalization housing, which is up to 6 months of housing after being in a hospital setting. Those are 2 of the services that we do provide only in San Diego under this contract. A lot of different services, as you can see. So let's move forward. One of the questions that came up was, why did we engage in this endeavor? It was a big undertaking. And so the first and most important reason was we were a pilot for both whole person care and health homes clients in San Diego. Our LA County also was a health homes pilot provider as well. So we already had a supply of clients that we were in the middle of serving, in the middle of housing in some cases, who immediately were going to lose the benefit of those services at the end of 2021, and that would automatically be grandfathered into CalAIM on January 1st of 22. So we wanted to make sure that we continued to provide that continuity of care, keep those individuals moving towards housing, or continue to stabilize them in housing if they were already there. The second thing is we had a workforce that was providing support to those individuals. We did not want to have to send that workforce on its way to go looking for other jobs. We'd already gotten them trained up and aware of how to serve this population. So we wanted to retain them, obviously. But also we wanted to have a way of being able to increase capacity for community-based referrals. So many of our grant-based programs have closed referral sources where they come from a single source. So anybody that knocks on our door and says, I want services, doesn't have an easy pathway in. With CalAIM, we have the ability for the vast majority, almost everybody experiencing homelessness, to access services through the CalAIM mechanism. And that is something that we really, really wanted to make sure that we had available. And finally, just because we do believe in whole person care, we wanted to make sure that we provided those ongoing services to the community in a way that we know is holistic and housing first, that really focuses on getting people into housing, making that their priority. We can go ahead and move on. Thank you. So some of the early challenges in implementation really were because of the complexity of the program and because we bit off a really big bite by taking on 6 health plans and so many different services. So having multiple health plans and multiple services, each health plan, we had to contract with them. We had to negotiate for rates, and we had different rates for each service, sometimes not all under the same unit of pay. Some of them were monthly payment. Some of them were a per diem payment, for example, in our recuperative care. And some of them were a per encounter payment, depending on the credentials of the individual providing the service. So negotiating all of that, contracting for that, and budgeting for that were obviously really challenging on the front end. The referral and authorization workflows are unique for each plan. They don't all use the same systems. They don't all use the same processes. So learning that was a collaborative effort between the plans and the providers, trying to understand how do we navigate this new landscape that we're in. They didn't all use the same billing systems either, so or processes. So for some of them, we would use their care management system to enter our entries about care, and they would generate the payments from that. In other cases, we had to use a third-party claims processor to submit claims. And in other cases, they wanted us to go enter our claims through a portal. So learning again how to navigate different systems. And in some cases, the health plans would use one process for their enhanced care management and another process for their community supports. So made it extra challenging and fun. Understand that the health plans and the providers were learning from DHCS, Department of Healthcare Services, as we went. New information was being rolled out post-implementation. And so everybody was scrambling, just trying to figure out what the landscape looked like. Another big challenge that we experienced was we were used to having a case manager that could provide wraparound services to clients. And with CalAIM, the system was designed to require separation of enhanced care management services from community supports. So we could not have the same individual providing both services, which made staffing very difficult because we had to right size both our ECM and community support staff, and they were not always even and parallel. So that was challenging. And then the lack of pairing with rental assistance. So one of the big challenges is the cost of rent in San Diego is very high. The available affordable rental market is very, very tight. And so rental assistance is really a pretty essential component of a successful housing strategy. And the fact that it was not paired with this program meant that we were having to look for other sources for rental assistance and supports. And then sustainability of the client base is really challenging. Most of CalAIM does not it provides little to no outreach dollars. So knowing that we're expected to graduate clients once we house them or once they're stabilized in housing, trying to identify new clients and maintain the ability to continue to serve was a little bit of a challenge as well, and continues to be. So some of the successes, we successfully transitioned 200 members from grant-based to fee-for-service. None of them had a break in care. Now, we went through about a month and a half of trying to make that happen, but we continued serving them on the confidence that we were ultimately going to work it out, and we in fact did. And so we continued to serve clients through that grandfathering period successfully. We have served in San Diego alone nearly 300 clients at this point in CalAIM, and have 150 still currently enrolled and receiving services. I think the greatest shining star of all of this has been the collaboration between the providers as well as 211 and Community Information Exchange. It has been a real opportunity for us to come together as a community and solve problems collectively. A great example of that is we have a group of us that provide those recuperative care services, and we were not filling beds even though we knew the demand was there. So the providers shared information about availability, and we now have created a tool where we can find real-time updates about which locations have beds available for each individual health plan. I am aware that I'm over on time already, so I'm going to step it up a little bit more so that we have enough time for Q&A at the end. I will say that the grant funding for startup, both they're called path-cited funds, as well as IPP, which is incentive payment plan, are both excellent opportunities for getting organizations started in providing services or increasing their capacity. And then increasing data sharing. There are two opportunities that we're working with 211 on one of those, but the data exchange framework and authorized sharing of confidential medical information is giving providers access to healthcare information upon authorization from the member. And that is something that community-based providers have not had access to for a great deal of time, and has often gotten in the way of our ability to provide those services. Okay. In terms of lessons learned, just learning about the process of claims and being able to take what was all grant-based work and figure out how to navigate all of the medical system has been something that was a real learning experience for us. And we've certainly tightened up our belts on being able to do the reconciliations behind that. If we were to do it again, we would have tried to find a way to make it a simpler startup with fewer plans or fewer services so that we could have stepped slowly into it. I'm not sure that was actually possible given that we were grandfathering, but it would have been something we would have tried to take a look at. And then the other thing that we're just now really trying to wrap our head around is how we can better braid Medicaid funding and services together rather than trying to have a standalone program, because really that's the way that CalAIM was intended. And we're finding that it's the only way to really make it sustainable in the long term. So an example of that is we're looking now at trying to incorporate enhanced care management at our permanent supportive housing sites so that we're basically upping our game on the level of care being given to existing members rather than trying to serve additional members necessarily. And in terms of opportunities, we really are leaning in right now to trying to really improve our collaboration with the managed care plans. They hold a lot of power in the situation. And so it becomes really important for us to be sharing information with them about what's working and what isn't, and to really get buy-in from them around things that will make it work better. We really think that greater transparency in being able to see who clients are already connected to would be extremely helpful for us in being able to connect them to other services and to get referrals processed. We are beginning now to start targeting our outreach into hospitals so that individuals coming from hospitals can have a recuperative care bed to stay in or be connected to ongoing services once they've been discharged. And then we also in San Diego are looking at how we can strategically re-enter the enhanced care management experience. We had stepped away from that at one point because it was not sustainable in the model that we originally began with. So we're hoping that we'll be able to step back into that world. I appreciate your time. At this point, I'm going to pass it back over to Carrington so that you can finish us up.
Thank you so much to you, Glenn, and to the rest of the research team for providing some updates on what you've done this far in your research and kind of where you're headed and your next steps. As I mentioned at the beginning of this webinar, they are in the first of 3 years of their Systems for Action grant, and we will have them back to do some more research and progress webinars, so you can follow along with their progress either via email that we will send out, or I will pop in the chat their website page on our website so that you can follow along with any products or dissemination opportunities that the team is doing. So with that, let's move into our Q&A portion of today. We have about 10 minutes to go over some questions. I know that we have gotten some good ones in so far. Please don't hesitate to put any other questions that you have in the Q&A. If we don't have time to address them today, we'll make sure that the research team has those questions and can reach out to you at a later time. So with that, our first question here is from Jean McGuire. Some of those services were in prior waiver or state plan services. Did the waivers all get rolled into the managed care plans?
It's a great question that I do not know the exact answer to. Karis or anybody else on the call know the details?
I mean, the way that it's operationalized, and I mean, there's different funding sources. The health plans are really the owners. It comes from DHCS, our Department of California Health Services, and then it's distributed to the health plans are making the decisions. Although there's like policy and regulations that the state is requiring the health plans to follow, the health plans are the managed care plans are essentially the ones that are making the decisions on how to implement those policies. Yeah. Glenn, did you say any differently? Oh, sorry.
Well, I was just going to say, Jean, what I can say also is that whole person care was a different model, right? Where it was the counties that were doing that. It was for those who aren't familiar, it was a program that focused on high needs individuals, a lot of focus on the unhoused. It was run by counties, and it did involve a lot of collaboration between counties, healthcare, et cetera, but it wasn't run by the plans. So now everything goes through the plans in terms of ECM and community supports, but exactly all of the details of like the policy nuances, I'm not sure I know of, but would be happy to try to find out more.
Health Homes was also a pilot that was a Medi-Cal waiver as well. And it was really laying the groundwork for this, and it did expire at the same time that CalAIM began.
All right, thank you all for addressing that. We've gotten a couple of questions from Catherine Couch. So I will do my best to address some of these. And I know that you kind of addressed this question, but I'm gonna see if there's anything additional you'd like to add. But they mentioned that there are some case studies that the Center for Health Law and Policy Innovation at Harvard Law are doing around MS/FNS benefits. It will be good to see and understand those as not to duplicate efforts. And you did mention that you were working with some other organizations so that you weren't duplicating efforts, but I'm curious if you want to say anything else about that.
Yeah, Catherine, thank you so much for that comment. We have seen those case studies. We're trying to follow everything that's coming out, from that group. CHCF, the California Healthcare Foundation, is doing a lot with also Center for Healthcare Strategies. Anyway, we're working on really kind of building up relationships with all sorts of different organizations. We've been talking a lot with the CPI, the facilitators of regional or county specific collaboratives that are also supporting organizations implementing CalAIM. We're also working with different topic specific groups. So we are aware that there's a lot going on, and we're trying to make sure we're not duplicating. And that's part of the why we actually joined forces with the California Healthcare Foundation on the survey, because after we were funded, we found out that they were also doing a survey. And so we didn't want to do two surveys at the same time. So yeah, we're trying to be as non-duplicative as possible.
Thank you, Caroline. Okay, Catherine's next question here. They mentioned that I'm guessing CHCF is Colorado Healthcare Foundation. Could be wrong.
California.
Is that right?
California Healthcare Foundation, yeah.
All right. Has been supporting a group of CBO leaders to understand their experience and to provide feedback to the Department of Healthcare Services. Given the numbers, a very small share of CBOs are participating. Is there data about the number of community-based organizations contracted by county? Because it would be good to understand the issues for rural communities.
Yeah, that's another great question. And I can maybe kind of turn that over to Abby to talk about that, and also the next question around kind of the issues around participation that we are planning on doing as part of our survey. Abby, do you want to say a little bit about those?
Yeah, sure. I think these questions, they hit the nail on the head of some of the big issues of why we need to include both CBOs who are and are not participating in CalAIM in our survey. And we would love to have data on the number of CBOs contracted by county. And we're trying to work to get that, whether that's through the state or through California Healthcare Foundation. We're still working on that because there is this big question of who's contracted, and then also what's the denominator of who are the eligible contracting CBOs. And I think, this rural issue and also this issue of out-of-state for-profits definitely on our radar. And I think one of the key reasons that we're hoping to kind of elevate the local CBO perspective to find out what are some of the barriers to those intended CBOs participating that are maybe getting supplanted by some of these larger organizations, and how are some ways that either MCPs or the state through technical assistance can really reach and include those targeted CBOs.
Great, thank you, Abby. Okay, and then Catherine's last question here, which I know there's been some conversation in the Q&A between her and Julie Lawrence, but they talk about how it would be helpful to understand where MCO plans are using out-of-state for-profit organizations rather than California community-based organizations, and why this is a big issue for some community supports and is counter to the Department of Healthcare Services goals to build local capacity.
And I think that's sort of what I was speaking to, but I think, you know, CalAIM as it's written is sort of a test case of this question of, can plans work with these local CBOs, and does that make sense, and is that the best way to deliver services? And so that is definitely a big piece of what we're looking into here.
Great, thank you. And I know there have been some conversation and some emails shared between these two, and potentially I'll grab those emails and get those contacts to your research team in case there are any follow-up conversations that could happen from that. Okay, moving on to our next question. I think we have time for maybe one or two more, so we'll move on to one from Mark Rosen. How might the research and/or communities of practice identify helpful solutions from either a policy or community-based organization implementation perspective around removing barriers to entry for community-based organizations and CalAIM contracting? The themes mentioned in the communities of practices seem more operational, which is valuable, and it also seems like there's a preceding step for CBOs to just connect to the work and see themselves in it and carve out dedicated time to exploring the opportunity. That was a long question. Let me know if you'd like me to repeat anything.
No, that's a great question, Mark. And I think that's, I mean, and Glenn can speak to, we locally in San Diego, these are the same issues. There's a lot around retention, like workforce development and having people actually staff, and Glenn can speak to that. And then also just contracting in general. In San Diego, there's also 6 health plans, as Glenn mentioned. So these are like the first and foremost challenges. I think it's like across the board, everyone's seeing those challenges, but they also are the most complicated to address. And so I don't know, Glenn, if you have thoughts on that, but so that's kind of where I think we see that, but the community practice might be looking at some of the other ways in which we see like we could make change quicker. But Glenn, what are your thoughts?
Sure. I think that the opportunity here really is in helping DHCS understand where flexibility is helpful and where flexibility is less helpful. They embedded a lot of flexibility for the health plans to make a lot of independent choices about how they implemented it. And in practice, we're seeing that creates a lot of complexity and barriers to access for some of the community-based providers. I know that we've had conversations directly with DHCS and with other organizations doing some of this work, but so much of it has been kind of qualitative conversational. And I think that the collection of information about the experience of providers and individuals receiving services is going to be really helpful in defining what crispness might need to be added to the programs in order to make it easier for other providers to provide those services.
Thank you, Karis and Glenn. Okay, we have 1 minute left. I know I said we had time for 2 questions, but I think I'm going to cut it off there because we have a couple of announcements that we want to make. So for everyone else that did submit a question, we'll make sure to get this to the research team and have them reach out to you with some answers. And thank you for taking time to submit your questions and for joining us today. The first, can you go ahead to the next slide, Caroline? Thank you. First announcement is that if you are needing a certificate of completion for today's research and progress webinar, there will be a very brief survey at the end of today's presentation. You can fill that out and we will get you a certificate of completion in a timely manner. At the next slide. And this is an ongoing research and progress webinar where we have a presentation every 2 weeks. On July 5th, we will have our team from the University of Washington presenting on their research, Achieving Reach in Youth Behavioral Health and Wellness Through Catchment Area Community Governance. So we hope that you join us then. And in our follow-up communication, where I will share the recording and the PDF from today's slides, we'll make sure to also include the link to register for that webinar. And with that, we are going to end right on the dot. Thank you so much to the research team for presenting on all of your research. We're excited to learn with you over the next couple of years. And thank you for everyone who joined today. I hope you have a wonderful rest of your day.